Good afternoon, and maybe good morning to some of you, depending on where you are joining us from today. My name is Jessica Lopez Ricard, and I am your host for today's webinar on the role of palliative care for patients with vasculitis. I am also a patient living with GPA for almost 4 years now. Welcome to this webinar. I wanted to remind you that this is for you, so feel free to ask all the questions that you feel necessary during today's presentation and put those in the question box. Also, if you can, please turn on your closed captioning. So if you go to the bottom of your screen, if you don't automatically see it there, feel free to click the More button, which has three dots, and there you will see the option to do the closed captioning option for your on your screen. Also, I wanted to thank Novartis for sponsoring the Vasculitis Foundation webinars. Without Novartis, we cannot make this possible. So thank you. And also, we would like to thank our speakers. And when I go ahead and present them, I would also like our speakers to mention if they have any disclosures. Dr. Michael Goodblatt is a palliative care physician at Providence St. Peter Hospital in Olympia, Washington. He received his medical degree at the University of California, San Diego, followed by a residency in family medicine at Harbor, UCLA. He then provided primary care in Anchorage, Alaska for 5 years before completing a fellowship in hospice and palliative care at the University of Utah in Salt Lake City. He has been providing inpatient and outpatient palliative care since 2019. Kim Brown Rechner, RN BSN, is a palliative care nurse at Providence St. Peter Hospital in Olympia, Washington. Kim has been a nurse for 26 years, the last four in palliative care. Her current role is as palliative care RN in the emergency department. Prior to palliative care nursing, Kim spent most of her career in the ER and ICU. Dr. Goodblatt and Kim Brown, welcome to this webinar and thank you. Do you have anything to disclose?
No
Nothing to
disclosures.
disclose. No disclosures.
Awesome. Thank you so much. Before we begin your presentation, I'm going to go ahead and do a quick poll to see what kind of get a feel for our audience this afternoon. So I will go ahead and show that now. If you can please take the time to respond to the questions that are on your screen, and I will show the results afterwards. So there are two questions. Number one, how much do you know about palliative care? And then number two, have you ever discussed palliative care with your doctor? Going to give us about 5 more seconds. Okay. Get the last responses there. 3, 2, 1. And here are our results. So about 25% know nothing, 38% know a little, another 25% know a moderate amount, and then 13% of y'all know a lot. So I will go ahead and let you look at that first result. And then number two, have you ever discussed palliative care with your doctor? 38% of you have, and about 63% of you have not. Thank you all for participating in the poll. And now we're going to go ahead and turn it over to our presenters, Dr. Goodblatt and Kim Brown Rechner.
Thanks very much, Jessica. I'm going to share my screen. Just 1 second. Okay. That should be showing up now.
Mm-hmm.
Okay. So thanks for joining us today. Again, I go by Mike. This is a lot easier than Dr. Goodblatt. Hard to pronounce. And I think Kim goes by Kim, right? Kim?
Mm-hmm.
Okay. So today we want to discuss with you all just about palliative care, kind of general introduction about what it is and the benefits of it.
I get to read to you for just a moment for the auditory learners. Palliative care is a specialized medical care for people living with serious illness. This type of care is focused on providing relief from the symptoms and stress of the illness. The goal is to improve quality of life for both patients and the family. The care is provided by a specialty trained team of doctors, nurses, social workers, chaplains, and pharmacists who work together with a patient's other doctors to provide an extra layer of support. Palliative care is based on the needs of the patient, not on the patient's prognosis. It is appropriate at any age and at any stage of a serious illness, and it can be provided along with curative treatment. And that information is coming from getpalliativecare.org.
Is this one me?
Yeah, I think it is. Sorry.
Okay.
Yes.
So just one other definition. It's kind of it's a field that not many people are that familiar with, and it's not as clearly defined as other fields may be. So we have kind of four different definitions here to kind of cover some of the various nuances of it. But this last one is palliative care is an approach that improves the quality of life of patients, both adults and children, and their families who are facing problems associated with life-threatening illnesses. It prevents and relieves suffering through the early identification, correct assessment, and treatment of pain and other problems, whether physical, psychological, or spiritual. And that's by the WHO. But really the core about it is quality of life. And that's the main focus, regardless of what other issues are being addressed.
Dr. Mike, this is you.
Thank you. So one of the most common questions that we get, and that I think is a really important question to address early on, is the difference between palliative care and hospice care. And the way I usually describe it to our patients is that, in my point of view, palliative care is kind of the larger umbrella, and hospice care fits under that umbrella. So it's palliative care that's specific for patients who we believe to be in the final months of life, whose main goal is to prioritize comfort over life prolongation. So I'll just kind of read over some of the slide points that they're there, as Kim was doing. So palliative care is for people at any stage of serious illness. So that means that sometimes we see patients with a new diagnosis of cancer. We see them at the very beginning of their diagnosis before they've even begun treatment, and then may follow them at different points throughout the treatment and into the future. It can be concurrent with curative treatment. So someone can be receiving, you know, complicated immunotherapy regimens or biologic agents for vasculitis conditions, and see palliative care at the same time. Whereas if someone were on hospice, they usually cannot continue those treatments to prolong life that they would be otherwise. Palliative care can be there when there are difficult decisions to make regarding care. So if someone's dealing with challenges regarding treatments that may greatly impair quality of life or may affect function or cause a lot of other side effects, and patients kind of choose whether they want to pursue that treatment or not, we can help provide guidance and be kind of a sounding board, help them weigh the pros and cons of different things they may be dealing with, help them make the best decisions based on what their values are. And then help with proactive planning. So as I mentioned, kind of goals of care, figuring out what treatments make the most sense, now in the immediate and short term, as well as advanced care planning, thinking about future care needs down the road, things like life support or CPR, or who you'd want to be your voice if you couldn't speak for yourself. These are all things that we can address through palliative care. Hospice care, as I said, is more kind of a specialized subset of the patients that palliative care may see. So it's for patients who um, are estimated to be within the final 6 months or less of life if the disease runs its natural course. That doesn't mean that they must pass away within 6 months. Some people have been on hospice for over a year, occasionally 2 years I've seen, but not as often. But that's just kind of if their prognosis meets that threshold. And care is primarily received in the home. So the idea is that hospice comes to where you are. So whereas palliative care is usually office-based or in the hospital, sometimes there are home-based palliative care services. Hospice is always about coming to where you are to minimize barriers. And so many people in hospice may be at home with family or hired caregivers. Others may be in an adult family home or um, long-term care facility receiving hospice services there. And the goal is to provide maximal symptom control to support quality of life while no longer pursuing treatments to prolong life. So, as I mentioned earlier, with hospice, the goal is to not try to do things to artificially prolong someone's life, but primarily to maximize their comfort, quality of life, help them to live the best life they can with the time they have remaining, focusing on time with family and friends and being in their pets and loved ones, being in their own environment as often as possible, and kind of demedicalizing their life. So not spending their time in doctors' offices all the time, in the hospital all the time, dealing with labs and studies, but really paring things down to what the core care is needed to help them be comfortable.
What we hope you get out of this today is figuring out when is palliative care appropriate. How can palliative care help someone with vasculitis, and what palliative care cannot do. There's a few things we cannot do, and then of course how to access palliative care. Ideally, like Mike was saying, any stage of a serious illness that can be in the hospital. We happen to have a clinic in our community that also sees patients who may be seeking curative treatment or management of some side effect of their treatment or illness. Um, Ideally, starts when the serious or complex diagnosis is made. Um, we can definitely work with concurrent with curative treatment. We love to see those patients. And when there's complex symptoms to manage. A lot of times oncology clinics do a great time of managing symptoms, but maybe they just need a little bit more support, or the patient needs more support, and we're happy to help in that area. We're certainly available for when difficult decisions are needing to be made about care, if they're at a fork in the road and need some help navigating um, kind of what's best and what aligns with their goals and values. We're helpful with that. And of course, when there's conflicting goals, and sometimes the conflicting goals are within the family, we can help navigate that also.
I think this
Is
one's me, right?
Yeah.
Okay. So, potential symptoms that palliative care may manage. And we use the word potential in this slide for two reasons. One is that symptoms may vary very much person to person. And the other reason is that across the country, there are many different setups or versions of palliative care or how it's being provided. So some are only hospital based, some have clinics, as I mentioned earlier, some have home-based palliative care. And some teams may manage pain or other symptoms, some teams may not. Some may just be there to address goals of care and advanced care planning. So what we describe here in this presentation may not necessarily reflect what is actually available in your community. And so if you do decide to pursue palliative care now or in the future, just be aware that it can vary a lot based on where you live and over time. And so it's good to reach out and find out what resources are available in your area to get a sense of kind of what options you may have in the future. But in terms of general things that we are trained to do, pain is obviously a big one. A lot of our patients that we see for various conditions deal with pain. Sometimes it's pain that's tied to what we call their life-limiting illness, the reason that they're seeing us for. Other times they may have chronic pain conditions that are completely separate from the specific diagnosis that they're seeing us for or overlap in some way. And so oftentimes for our team here, we try to focus on the pain that we believe to be tied to the life-limiting illness. And so, for example, in our clinic, if we see someone who comes in with advanced heart failure or advanced kidney failure or cancer, and they're having pain tied to the disease, which is minimal, but they have severe chronic back pain and they're being followed by an outside primary care provider or pain specialist, then usually we'll defer the pain management to who they are seeing or to an outside doctor. And we try to focus on the symptoms and pain that's tied to the disease that we're seeing them for. And that can be a little hard to figure out sometimes, but that's kind of what our goal is. Some patients may experience shortness of breath, call this air hunger sometimes. People, especially in late stages of illness or closer to the end of life, or if they're in the hospital with an infection, may experience restlessness or agitation that could be tied to delirium. So with delirium, that's kind of an alteration of your normal cognition. So people may have higher levels of feeling very sedated. They may be almost knocked out, or they may be very restless. They may be having hallucinations or delusions about paranoia about things that are happening around them that can be very unsettling. And so we try to help to calm and manage these symptoms. Um, Fatigue is a very common symptom for a lot of different illnesses. It seems to be kind of a core symptom that a lot of different illness pathways present with and can be very tough to manage. Constipation definitely is one that we see a lot. It may be tied to an illness directly, or it may be a side effect of medications we're using to treat other symptoms, such as using opioids or narcotics to treat pain. Oftentimes they cause constipation, and then we have to treat the constipation as well. Nausea is also a common symptom that oftentimes is a side effect of treatments that people are undergoing. And we are trained in the use of certain medications that may not be commonly used in this way in other fields of medicine. So that's kind of one advantage of our involvement, maybe thinking outside of the box in terms of how to use medications in different ways that may not be what you would normally encounter. Anxiety and depression are also very common symptoms for a lot of different illnesses. A lot of people dealing with a serious long-term uncurable illness, it's common to feel anxiety about the future, about what their life may be like, about what the course may be in the future, about their level of function and independence. And that can definitely lead to feelings of isolation, depression, sometimes guilt, other times just feeling like they can't connect with those around them. And that's tied to loss of hope, feeling like a lack of control over what's happening with your body. And these are symptoms that, you know, our service, along sometimes with counselors or mental health providers, primary care providers, can be sometimes very helpful to help manage these symptoms and help find supports and outlets so that patients have the help they need to kind of feel a little more at ease with their situation, which can come with time. And then, as I mentioned, side effects of different medications or treatments or adverse effects from treatments can be things that we try to address in collaboration with your other specialists and doctors. So living with vasculitis. So this one we didn't put too much in because we don't want to tell you about what symptoms you're having or what things you're living with. But we do know that there may be some common symptoms that a lot of people may experience or may not. As I mentioned, fatigue is a fairly really common symptom for a lot of conditions based on where in your body and what type of vasculitis you may have. Pain may be a factor, anxiety and depression, as I just mentioned, and then side effects from treatments. All treatments, the goal is really to control the symptoms, to keep the vasculitis from flaring up and causing more damage. But these treatments can cause their own side effects, such as increased risk of infections if they're biologics, as well as other side effects like nausea that are pretty common side effects with a lot of medications. And so these are things that can vary that some of you may never have, or some of you may have all of them. And so palliative care can hopefully be a resource to help you manage and mitigate some of these side effects and symptoms.
Common ways palliative care can help, and our team. For us, we have a large team. We work with you and your family to address physical, some emotional, spiritual, and existential impacts of your diagnosis. It's not just a visit to your PCP. It's pretty comprehensive, and it looks at the whole person and the whole situation. We also can coordinate care with the primary care provider and or your specialist, your who you're seeing for your specific condition, to coordinate the best management of your symptoms so that everybody's on the same page and the care is really coordinated. We'll also look at outside resources such as counseling and support groups. That seems to be a level that we have our finger on the pulse of, or palliative care often does, to connect you with that. And then have open discussions with you and your family about your goals of your care and the help with advanced care planning, such as completing documents, directives, power of attorney documents. Palliative care doesn't do anything typically with having to do with wills or financial documents, but we will help you suss out who will speak with you if ever you're so sick that you can't speak for yourself. And then also document your wishes around CPR and life-saving measures.
And in terms of our teams, and again, that again will vary place by place, but on our team is definitely, I think, kind of an outlier. We're very well staffed. We have several doctors on our service. We have a few advanced nurse practitioners. We have several RN nurses. We have a palliative care trained pharmacist who specializes in complex symptom management to help us along. We have access to chaplains in our hospital, our spiritual care team, and we have social workers to help patients navigate what resources they may be able to access either through their insurance or through the VA if they're a veteran or through their community and private pay resources as well. And in terms of coordination of care, you may have experienced this yourself, but oftentimes, at least in the hospital, it can be that someone is being seen by five different services, and each doctor that sees them is not really communicating that well with the other services. They're all kind of doing their own thing. And because we're not focused on any one specific organ or body system, we're allowed to kind of have a more expansive eagle eye view of the global picture. And so we can sometimes be a benefit in terms of help patients to understand what is going on, what the different voices in the room may be saying, and how to bring those voices into unison, whether that might be speaking one-to-one with the different doctors on different services, or sometimes organizing a care conference that includes multiple disciplines in one discussion so that everyone is on the same page and unified in support of what your goals and your priorities are. And I'll say that the counseling and support groups is a really great resource that not everyone utilizes, and I understand it's not everyone's cup of tea, but especially I think given how a lot of these conditions can make people feel very isolated, that no one knows what they're going through, their family doesn't understand, they try to support them, but they don't know what it feels like to have this condition, and that can be very isolating. And a lot of people want to spare their family from knowing the different stresses that they're experiencing. They don't want to burden them with the stresses that they're feeling and what they're going through or what their worries are. And so they keep it inside. And so sometimes having a counselor who is not tied to your family, there's no conflict there. There's no red tape. You can be very open and raw with them. That can be extremely beneficial. And having support groups with other people going through what you're going through, that can just be really not rewarding, but reassuring, knowing that you're not alone, that there are other people who are experiencing similar things to what you're experiencing, and to be able to share that with each other, to share the frustrations, to share things that you have figured out and workarounds and ways of dealing with things, of dealing with family. that can be extremely beneficial. So if those are things that you may benefit from, I definitely recommend talking with your specialists, talking with their support teams and groups, and seeing what resources exist for you. And nowadays, a lot of them, there might be online resources where you don't have to leave your home. You can do a Zoom visit like this with a support group or provider or a counselor, and that can be really beneficial.
We are also really good at helping you clarify what your wishes are. We're going to ask you what's important. And in the event there was an emergency, we would hope to have those wishes documented and for your family to understand what your choices are. We do documents here in Washington State. Many states have a form called a POLST. We call it a POLST in Washington State. It's a portable order for life-sustaining treatment. Other states call it a MOLST. It's a signed physician order that typically resides in your home or where you live that would give EMS or your 911 services an idea of the care that you want, and more importantly, the written instructions on the care you don't want. And we help you complete those and navigate you through the process of decision making to figure out what's most important. And we can also help assist with advanced directives. We can help with power of attorney documents, which are really essential with a complex or life-limiting illness, just to have somebody who can speak for you in the event you can't speak for yourself. If you came into the ER, I'll give you a really brief example. Sometimes we have patients that come in that have altered mental status from something as simple as a urinary tract infection, and we just need to be able to talk to a family member who understands the patient's goals. And so a power of attorney document is really helpful because then we can have a conversation with the power of attorney that that knows what's important to the patient. So we can help navigate through those. And ultimately, decision making comes from assessing what your goals and wishes are, what you're willing to go through or not willing to go through, and that aligns your treatment then aligns with your goals and values. And then we make an effort to document that and also let the people who you want to be a voice for you also know what your wishes and goals are. We can definitely do power of attorney documents. Those are not financially linked to anything other than your health care. And ensure that, of course, your loved ones know what you want, and hopefully they honor your wishes when you can't speak for yourself.
And just a few more points about that too. With the top point about things like CPR and life support, um, you know, what I often tell patients is that for most of our lives, the things that we do to help us live longer, the things that we do to help us live better are the same things. So if you're sick and need antibiotics, that helps you with both goals. Um, if you have, complex vasculitis, the meds that help control the disease and help you live longer usually also help reduce the symptoms tied to the disease. So those two goals kind of run together in unison for most of our lives. When someone reaches a point where they have really advanced stage disease or complications, or they're very old and having health issues related to that, that may not be tied to vasculitis in this case, there comes a point where the things that we normally do to help someone live longer become less effective and they may become more burdensome. And so things like life support or CPR, while potentially very effective in someone who's fairly young and otherwise has very few health issues, are much less effective when someone is much older or has much more health issues or more severe ones. And so having to choose between treatments that help you live longer or help you live better is a really tough decision to have to make. And that kind of gets at the heart of we call goals of care discussions and advanced care planning. And one of our roles is to help think about, when we meet with someone, what their disease state is, what changes they've experienced at home in the last few months, what the future may be like in terms of what complications they may experience, trying to assess what may occur and then what options would be if that happened, if that did occur, and knowing kind of sharing what we think about the odds of something being beneficial or not, or helping them reach their goals. So really it's about figuring out what your core life wishes are, which is hard to do in and of itself, and then figuring out what treatments or medical decisions best support those goals and which ones may not best support them. And none of this is intuitive. None of this is common sense. Um, we it's hard for us too, and this is what we do all the time. It's never easy, but we do our best to help people figure out, what their priorities are and what best supports that. And in regards to the surrogacy or power of attorney part, every state has their own laws about who would be the default surrogate. So if you end up in the hospital and you are confused or very sick or intubated, every state will have a list of priority regarding who is the first one the hospital will call to talk to be the one to make decisions for you or on your behalf. And oftentimes it's a legal spouse as the first, an adult child as the secondary, and then maybe siblings or adult parents, or nieces and nephews as you go down the list if people are not available or are not in someone's life. Um, but there are times when maybe someone is separated from their spouse, but not divorced legally, but they don't want that person to be the one to help make their healthcare decisions. That's why doing a power of attorney form is really important. So it allows you to bypass the default state hierarchy to choose someone of your wish to be that person, whether it's um, a friend, a sibling, a child, several people, but it allows you to go away from what the state standard is, the default is. Another example is sometimes, you're an adult, you may have 4 or 5 adult kids, and two of them are level-headed, they know your wishes, they are willing to and able to honor those wishes. And you may have, one kid who's more emotional or has just their own ideas about what is best for your care, and they may not be able to move past that to do what you want for your care. And so you may not want them to be part of the group of people making decisions. And so again, by choosing a power of attorney and doing that paperwork, it allows you to name the people that you trust to really best be your voice, to best carry out your wishes, and not their own of what they think is best for you. And also with these discussions, we know that as time goes on, as your health evolves, as life evolves, your wishes and goals may change over time, and they often do. And so we try not to see these discussions as you do them once and then you're good for the rest of your life. That'd be easy, but that's not really how life works. Oftentimes is we have starting discussions. And if someone knows their wishes, then we do our best to document those wishes, whether it's life support, CPR, power of attorney, and then we plan to revisit them in the future. So I often tell people that, once you're getting a little bit on an age or have more complex health issues, maybe once a year, sit down with your family and your paperwork, and potentially your doctors or palliative care providers or family docs, and reassess your prior choices and determine whether they still reflect your wishes or if things have changed and a new discussion is needed. So that these are meant to be always there to reflect your wishes, but knowing that your wishes may change, the forms may need to change over time too. And it's really good to every now and then check back in because, especially with power of attorney or family, they can only be your voice as well as they know your wishes. And if your wishes change and they're not updated, they can't be in the best position to honor your current wishes. So communication with your family, with your friends, with your doctors is really crucial. So as I mentioned earlier, kind of got ahead of myself, I think a few slides ago, but some teams may only see patients with advanced stages of disease. So we mentioned that palliative care can start at the beginning of diagnosis. That is true in theory, but in reality, oftentimes palliative care teams may be very small, and so they may have to set up limitations on who they see so that they can provide the most good to the people who have the most complex needs or the most advanced levels of disease and not see all those who deserve to be seen, unfortunately. It's a limited resource. And so some people may only see those with a shortened prognosis of a few years, or really advanced stages of disease, or may see people, or may not manage pain or symptoms directly. They may give suggestions without prescribing medications, but collaborate with other doctors to help guide them on medications, or may only be based in a hospital and not have a clinic presence in your community. Other areas may not have any palliative care available at all. And so there are programs that use rural networks where there are hubs of specialist palliative care providers in greater metropolitan areas who use Zoom and telemedicine, telehealth to collaborate with patients or with local providers in more rural areas that are underserved to help collaborate to provide some of that specialized care or access it to help make sure that people's needs are being met. So, the hope is that over time, there'll be more trained palliative care providers, more hospitals will see the benefit of it and create more teams and grow them. But obviously, right now, as in true healthcare in general, there are a lot of gaps across the country and they vary in their intensity and severity. But hopefully, there'll be some way, whether it's directly or indirectly, for you to be able to access palliative care when it's needed.
Oh, and the big question on how to access palliative care. If you have palliative care in your community, the first place to start would be with your specialist or your primary care physician. And they might be able to know what resources are available in your community in regards to palliative care. There is a state resource guide called NASHP. You can find that online. And then Palliative Care Directory, Get Palliative Care. Is an organization on how to find a palliative care directory or a palliative care provider where you live. And I love this. This is one of Mike's favorite quotes. You treat a disease, you win, you lose. You treat a person, I guarantee you, you win, no matter what the outcome. And that's from Patch
And
Adams.
yeah. And we can't always change the course of someone's illness. Sometimes the medicines stop working, um, but we can always help treat a person and help them as they deal with their health as it declines. And hospice, as I said earlier, they're the experts in this when they're in the very final phase of life. Um, but there is always things that can be done to help somebody, and that's really one of our bottom lines is that Um, if you ever hear we can't offer you anything else, that's not really true. It may not
Mhm.
be the medicine that they're hoping to be able to offer you, but we can always do something to help you. And we want you to know that and know that that is always true. So I think that is all that we had. I'll stop sharing our screen now.
Wow. Thank you so much, Dr. Goodblatt and Kim. That really hit home. And for myself, and I know for many of the participants online today, I did get to that point in my journey where the doctor said that she wasn't going to be able to do anything else for me. That was exactly 2 years ago. And palliative care was not mentioned at all. And at that point, I could have asked my rheumatologist based on what you presented today, right? But if my life turned around, would I have been able to come off of it? Would you say?
Come off of palliative care, you mean?
Yeah.
Absolutely. Um, you know, in clinic, I say this a lot because we see people sometimes one visit, sometimes we see them once a month. It really depends on the individual case. And what I
Mhm.
always tell people is we don't want to be a burden. We just want to be a benefit. So if someone is seeing three specialists, they have visits every week or two, and they don't need to see us once a month or once every 3 months, we are happy to go as needed or to graduate them, knowing that if in the future things change, they can always come back and see us again. But yeah, if people don't need us, we're more than happy to be out of the way. That's usually a good thing.
Mhm.
Great, great. Yeah, that was a question that was asked as well, and from one of the participants. And so, if we are in palliative care, can that prevent us from qualifying for certain medications that are maybe required for our vasculitis?
My understanding is no. Palliative care does not change any of your other care. So if you're seeing rheumatologist, other specialist, seeing us does not mean you have to stop seeing anybody else or can no longer access any medications. I think that's often a confusion with hospice, where when you're in hospice, they become your everything. So you stop seeing primary care, usually another specialist. You can't get access to medications that are being used to help prolong your life. But with palliative care, there's no such limitation. We have patients on extremely expensive, extremely aggressive treatments that may be in and out of the hospital frequently, and we walk along them during those times.
Great. And we had another participant that said that they wish this was available 10 years ago when they almost died before being diagnosed. And so tell me, how long has palliative care been in existence, or is it becoming more and more well known by providers and their patients?
So it's been around for a few decades, probably in different forms, not always called the same thing. Sometimes it's called supportive care even now. A team may be called supportive care, not palliative care, because some people are afraid of the term palliative care because of what it may mean or be associated with. But it's been around at least for a few decades, but growing in popularity a lot over the last 20 years. It became a board certified specialty or subspecialty. And I think it was like 2006 or around there. Cam, I don't know if you know, probably not either.
Yeah.
But definitely it's become more, I guess, standardized within the last 20 years. And then just kind of growing by word of mouth, by exposure since then. Um, a lot of hospitals, I think there still is in some places, but sometimes pushback from other specialties that they feel they have these discussions, they manage medications, they don't need a whole other specialist to be in their way, taking away things that they normally do. And sometimes they're right. Sometimes they're really good at dealing with those things, having those discussions. But there are a lot of times where, their point of view is very focused on their background and their experience and their perspective. And sometimes they may have some blinders on that we don't. And we have our own blinders as well. But I think there's been becoming a growing acceptance of palliative care among different specialties as they see how it not only benefits their patients, but it benefits their own clinics. We know, locally with oncology, when we're there in our own clinic to help manage really complex cancer-related pain, that frees them up to focus on making sure that the chemotherapy they're managing and immunotherapy agents are working and able to focus more on the things that they're best at, and we can focus on what we're best at, and together the patients benefit the most. So some places it's still not as available, whether it's because we don't make money for hospitals. That's one problem is that, when a cardiologist or surgeon does a procedure, they bill that procedure, they bring an income for the hospital. We bill for what we do in our time, but it's a fraction of what other specialists make. And so hospitals have to pay to have doctors and nurses and social workers on staff and not make a lot of money from having them there. So they have to see the non-financial benefits as well as the financial ones in terms of saving hospitals money sometimes, but they have to
Right.
see the altruistic benefit of it, and that's not always a winning um, goal or winning argument for hospitals that have tight budgets. But it is growing, and hopefully in the next 10 years they'll be more prevalent than it has been in the last 10 years.
Great. That's wonderful. And so you did share a page that had resources on palliative care and how we can find it. So in the case that we ask for it, it's not provided, it's something that we can have access to, right? On the page that you mentioned.
It's one way to find a provider that's local to you. Um, and to see, sometimes your doctor might say, I don't believe you need a referral to palliative care. You could still reach out to a clinic or a palliative care team or physician and see if you can self-refer. Sometimes that's a possibility. Um, but yeah.
I smile because I think most of us living with vasculitis or any chronic condition know that we have to be advocates for ourselves. And we have become very good at it over the years of living with this illness. So I want to just thank you once again. And this is such a timely topic. And we hope that you'll consider visiting us again in the future. For those that just joined us on the webinar, maybe you got the time mistaken on a different time zone or whatnot, but this webinar, it has been recorded and it will be available for viewing on the Vasculitis Foundation website, as well as the YouTube channel for the Vasculitis Foundation. So when that recording is available, you will all receive an email, all of you that registered. And once again, thank you to our presenters. And also, I'm going to share my screen and thank the sponsor for this webinar, which is Novartis. So thank you so much, Novartis, for making these webinars possible and for just helping us educate the community. And then thank you for our presenters who took the time to present on this. And with that, we will conclude our webinar for this month and stay up to date with the Vasculitis Foundation webinars by visiting the website. Thank you so much.
Thank you for the opportunity.
Yeah, thanks so much for that, for the time.